Hello, my name is Mark Miller. I've been asked to speak about risk stratification and mitral valve prolapse. Effective risk stratification is challenging. Traditional risk factors are usually not present. The majority of sudden death occurs in patients with normal LV function, less than severe MR, and the risk is continuous and not dichotomous. So I'd like to take a multimodality approach to risk evaluation of sudden death in MVP. The first one is the technique is ECG or Holter, and the parameter is PVCs. As shown here in two studies from 2013, 2015 in patients who exhibited sudden death with mitral valve prolapse, the majority of patients actually had complex ventricular arrhythmias. If you look at a more recent study on the phenotype of MVP-related sudden death, 100% of the patients had PVCs, and nearly 100% of the patients had posterior papillary muscle PVC morphologies. And then in a more recent study, they demonstrated that mortality in arrhythmic MVP was stratified by ventricular arrhythmia severity. Of 595 patients, even in patients with mild to moderate ventricular arrhythmias, the risk of excess mortality, ICD implant, or VT ablation was 24% at 8 years. So having said that, if PVCs are present, and especially if they're complex or pleomorphic, it warrants further evaluation. The next modality is transthoracic echo, in which you can derive tissue Doppler, mitral annular disjunction, myocardial strain, and mechanical dispersion. This is an example of a Pickelhaub sign, which is a spiked lateral mitral annular velocity. And in this study of bileaflet prolapse patients, they demonstrated when the velocity was greater than 16 centimeters per second, 2/3 had VTVF and 1/3 had LGE or SCAR on MRI. This is a more recent study on the Pickelhaub showing that the presence of a Pickelhaub doubles the risk of developing VT. And when you use a cutoff of 19, it has a specificity of 72% for predicting ventricular arrhythmias. This is an example of mitral annular disjunction, another transthoracic echo finding, which is prevalent in 16% of patients with MVP and significant MR. And there is data to demonstrate that there's a correlation between the degree of mitral annular disjunction and the amount of fibrosis on MRI. And this is a study of MAD patients showing that with whether it's MVP or non-MVP patients, severe ventricular arrhythmias was present in 10% of the population. Another more recent finding on transthoracic echo in MVP patients is mechanical dispersion. This reflects inhomogeneous myocardial contraction and subclinical myocardial dysfunction. And in one particular post-MI study, they showed that a mechanical dispersion greater than 75 milliseconds had a 96% specificity for predicting VT and VF post-MI. If you look at a meta-analysis of mechanical dispersion in all comers, the specificity ranged from 55 to 92% for predicting major arrhythmic events. And there is data for mechanical dispersion in MVP. In this one particular study, they showed that patients with arrhythmogenic mitral valve prolapse had greater mechanical dispersion than either MVP without ventricular arrhythmias or controls. The next modality is cardiac magnetic resonance imaging, looking for LGE, specifically the presence of replacement fibrosis. Myocardial fibrosis is known to occur in 1/3 of patients with MVP and significant MR. It's typically localized to the basal infralateral wall or papillary muscle. And in this study, the incidence of major ventricular arrhythmia events was 7.7% in patients with MVP and LGE present, which was significantly higher than MVP patients without SCAR or MR patients not due to MVP. Future studies will need to determine whether the burden of SCAR enhances risk stratification in MVP patients as it does for other substrates associated with sudden death, for example, cardiac sarcoidosis and hypertrophic cardiomyopathy. And while most patients with MVP and complex ventricular arrhythmias have SCAR, not all do. As an example, in this one study, 1/3 of patients with major arrhythmic events did not have evidence of replacement fibrosis. So there is likely another proarrhythmic mechanism in these patients. And we looked at this in patients with undergoing PET MRI, looking for FDG and LGE uptake, FDG being a marker of inflammation. As we know, subclinical inflammation contributes to ventricular arrhythmia, SCAR burden, and worse outcomes. And in multiple studies using PET-CT or PET MRI, they demonstrated that a significant percentage of patients with high arrhythmic burdens had evidence of myocardial inflammation. And for example, in cardiac sarcoidosis, when you have the presence of inflammation and SCAR, it is especially proarrhythmic. So we did a study of 20 patients with degenerative MVP and significant MR and performed hybrid or simultaneous PET MRI. 85% of the patients were PET positive and 70% of the patients were PET positive and MRI positive. And if you break them down by complex ventricular arrhythmias to the left-hand side of the screen or minor ventricular arrhythmias to the right-hand side of the screen, you'll notice that in complex ventricular arrhythmias, 92% were PET positive. And if you compare the differences between these groups, the complex ventricular arrhythmia patients had more scar and less inflammation, whereas the minor ventricular arrhythmia patients had less scar and more inflammation, almost implying that there's a dynamic process going on. Future studies should evaluate whether the intensity of FDG uptake, for example, SUV, is associated with the severity of type of ventricular arrhythmias MVP, as it is for other conditions such as sarcoid. For example, in this particular series of patients who presented with ventricular tachycardia and sarcoidosis had a higher mean LV SUV than those who presented with AV block or controls. So my scheme for risk stratification MVP is that if a patient has complex PVCs, papillary muscle PVCs, and sometimes any PVCs, you do an in-depth analysis of the transthoracic echo looking for signs of myocardial dysfunction or other markers such as the Pickelhaub sign, mitral annular disjunction, or left ventricular mechanical dispersion. If those are present, consider doing either a regular cardiac MRI with LGE or a hybrid PET MRI looking for LGE and FDG. If those are positive, you can consider an EP study for risk stratification, a primary prevention ICD in especially high-risk patients, such as those with recurrent syncope, or mitral valve surgery if there is significant MR. In order to accurately assess the risk in MVP, we need more phenotype and outcomes data. We need to define the normal values for speckle tracking echo and the optimal threshold that predict ventricular arrhythmias. We need to define the thresholds of LGE and FTG that are associated with sudden death in MVP. We need to determine the predictive value of EP studies in the MVP population, and we need a multivariable risk score similar to other conditions. Thank you.